Friends, a very good morning, good afternoon, good evening to all of you who have joined us today. And I welcome you all to yet another episode of NTB Dialogues, which is a special CNS series presenting insightful and thought-provoking conversations with those who have spent years in fighting the world's top infectious killer disease. Today's session is a very special one on the theme of at least a century of inequities and injustices plaguing the TB response. Excuse me. Our star-studded panelists for today are my personal inspiration and friend, Nurse Virginia Allen from Staten Island, New York, author Maria Smilios from North Carolina, social activist Ila Gandhi from Durban, South Africa, TB and HIV advocate Tariro Kotatsa from Zimbabwe, Dr. Tara Singh Bam from Nepal, currently based in Singapore, equity advocate Sumit Mitra from India, and our friend Gabriella Leone, History Archives Manager at Staten Island Museum, New York. Gabriella is also co-curator of the museum's much talked about ongoing exhibition, Taking Care, the Black Angels of Seaview Hospital. TB is a dark and sad but real story of inequity and injustice. We conveniently refer to it as a disease of the poor, but shy away from saying the truth, that those who enjoy privileges, rights, entitlements, and live a life where there is no hunger, poverty, homelessness, and other forms of discriminations, there is less TB. It is the inequity that puts people at risk of TB. It is the social injustices that deny them timely and correct diagnosis, deny them the best of treatment, deny them social support and security, and put them at heightened risk of TB and even death. Some quick housekeeping announcements before we begin. Participants, please keep yourself muted while the speakers present. You can type your comments, reflections, and questions in the Q&A box, even as speakers present. We will take them up before close of the session. Without any further ado, I am honored to welcome Virginia Allen, who so graciously agreed to be with us today at very short notice. Over 93 years, 3 years old Virginia is a living legend in her own self. She is one of the 300 Black nurses who worked at Seaview TB Hospital in Staten Island, New York, during 1913 to 1961. In those days, tuberculosis was a leading cause of death among New Yorkers, killing thousands of people every year. TB still kills 1.3 million people every year and continues to be the #1 killer infectious disease. Seaview Hospital served as a sanatorium plus hospital for TB patients during those years of from 1913 to 1961. But the white nurses refused to work there for fear of contracting the dreaded disease that TB was in those days. So the hospital recruited Black nurses who broke racial barriers and became the backbone of the Seaview Hospital, risking their lives to take care of the people living with TB. These nurses came to be known as Black Angels. Virginia is one such Black angel who is with us online today. She joined Seaview Hospital as a 16-year-old trainee nurse in 1947 and worked there for 10 years. She was assigned to the Children's Building and trained to become a licensed practical nurse. She enjoyed caring for the children living with TB, despite the constant threat of getting infected herself with the disease. At age 93, she remains fit as a fiddle, drives her own car, and volunteers actively with several organizations. Only yesterday, she told me that she had returned to her Staten Island home after attending a convention of National Council of Negro Women in Baltimore. I have had the privilege of meeting her last month at Staten Island Museum, which is currently holding an exhibition called Taking Care on the Work of Black Angels. This exhibit is open for all till December 29, 24. Over to you, Virginia.
Good morning, Shubha.
Good
And
morning.
everyone up at 7 a.m. The sun is just coming up, and I'm delighted to be invited to participate today with you. And to be able to represent the nurses who worked at Seaview Hospital so diligently, even though their lives were in danger, but mainly because this was an opportunity for Black nurses who were unable to find jobs in the profession that they were trained in because of racism and the segregation of hospitals. Speaking of segregation of hospitals, Seaview Hospital was one of the 4 hospitals in New York City out of 29 hospitals that would hire Black nurses. So the nurses who came to answer the call for nurses at Seaview were happy to come because they would not be discriminated against, and worked on the front line. We were in the front line of tuberculosis long before the cure, doing what nurses do: take care of the patients to the best of our ability and follow the doctor's orders, of course. My being there at such a young age, I was quite innocent at that time, and I enjoyed taking care of the children. They were children like any other child who would have been at home, very inquisitive, anxious about being away from their parents. And they did require a lot of care, not mainly because they were sick, but because of their separation from their family. The training I received at Seaview Hospital really saved my life. The nurses were very well trained, and they were able to impart that knowledge to us younger personnel when we came to work at Seaview. And I attribute it to my being in good health at 93 years old and still capable of helping others. It was a wonderful experience. And as I grew older, I realized how important it is to remember those nurses who came before us. And I'm grateful that I am able to do so. Thank you.
Sorry. Thank you very much, Virginia. it was you who saved so many lives. And salutes to your indomitable spirit. We are really, really very glad. And you are such a source of inspiration to all of us, Virginia. Please keep the good work going. We need you for many more years to come.
Thank you.
I now invite our keynote speaker, Maria Smilios, an award-winning author and adjunct lecturer at Columbia University, Mailman School of Public Health. Maria has immortalized the work of the Black Angels through her book, The Black Angels, The Untold Story of the Nurses Who Helped Cure Tuberculosis. This book was published in 2023, and the book celebrates works that affirm the highest value of the human spirit. It won the 2024 Christopher Award in Literature. It was also a finalist for the prestigious Gotham Book Prize and chosen as an NPR Science Friday Summer Read for 2024. The book was also selected as one of the 2 finalists for the National Association of Science Writers Journalism Award 2024. Welcome, Maria. And can you tell
Good
us?
morning. Thank you for
Hi.
having me.
Yes, Maria. And we are very keen to know something more about your book. Also, what inspired you to pen it down? And what inspired you to become a science journalist? Do racism and health inequities still plague the world? Too many questions, I think, but you will provide the correct answers.
So let me rewind to the first part.
Yes.
I'm going to start off with the question of the science journalist because I think
Great.
it's an interesting question for me. Initially, when I was a child, I wanted to study science, and I had a 6th grade science teacher who was horrible, and I kept failing that year. And on the last day of he gave me back my final exam. He gave it back to me with this big 42 written on the top. And I kind of was like, oh, and he looked at me, he said, that's okay. You have a girl brain, and girl brains don't do science. Girl brains do poetry and get married. And so that had marked me for a long time. I didn't study science. I did poorly in math, and I studied literature and words, and I went on, and I didn't set out to do science. I started teaching high school, and then when my daughter was born, I during that while I was teaching, I had also been doing some freelance editing for Springer Science and Media, the publishing company. When my daughter was born, I stopped teaching and I went full time at Springer. And so that's kind of how I fell into the science part of it as an editor. I had been writing little articles, but they weren't very science driven. And then one day, while I was editing a book on rare lung disease, I came across a line where the doctor was comparing the medication he was hoping would work for this very rare lung disease to Seaview Hospital. He said, I hope it's something along the lines like, I hope it was as swift as the cure was at Seaview Hospital in Staten Island. I always loved the idea, the disease and the way it moved through cities. So I Googled it. And this article came up about the cure at Seaview Hospital. Now, I used to live about 20 minutes. I'm born and raised in New York City, about 20 miles from Seaview. And I had only been to Staten Island 2 times. So, I say it might as well have been in another country for me. So I found this really interesting. And it was the story of Seaview and how the cure was. And then tucked alongside was a story about Miss Virginia Allen and this other Black angel who's passed, and this cadre of Black nurses. And so that's why I became curious about that story. And I Googled it and nothing came up. And then a couple of days later on a lark, I called the museum and I asked them if they knew about Virginia. And they said to me, yes, as a matter of fact, she's going to be at this grand reopening. This was back in 2015. And you should come down and you can meet her. And so that's what I did. I went down with my daughter. We talked briefly. We exchanged information. And then I just started kind of talking, and the story took off from there. She invited me to her home. She can tell you where she lives on this restored nurses residence, which is part of the larger Seaview complex. And I started digging into the story. Dr. Robichek's son was alive. He gave me his father's archives. From the archives, I tracked down the original INH patients. And then it just kind of took off from there. It became oh, you should talk to this person, you should talk to that person. And that's how the story came about. So that's the very short version of like 8 years of the book, that it took me 3 iterations, 2 presidencies, a pandemic, actually 3 presidencies. It came out in the 3rd presidency, a pandemic, yeah, for it to be published. So that's the bigger story of the book. There was a question that you asked me that was like 2 or 3 parts.
Yes, yes. First of all, I want to just comment on what you said just now, your very interesting start of journey as a science person, that things are only slightly better today, at least in the global south, very slightly better, where education and occupations are considered, they are still very much gendered. Like men are from Mars and women from Venus, that still holds good in our society. And
It's gotten better. Here it's
yes,
gotten better.
yes, yes,
But I know that those types of remarks to young children happen
yes,
all the time. And
yes,
I mean, I think, that last week when they, told me that I was a finalist for this National Journalism Award, the Science Award, I was it was one of the things that made me so happy, because I just thought if that teacher was alive, he could see
yes,
that I could do science.
yes,
But yes, I mean, that is, I say things have gotten better here, but it's still, we are still have a long way to go. And that was partially, well, actually, that was one of the driving forces of why I wrote this book. So it's a story about women in science, Black women in science, and they had been erased from this narrative that was very, very, very male oriented.
yes,
And I'm not saying that the men don't deserve the accolades which they received, but the women who helped these trials, had it not, Dr. Robichek said, had it not been for the Black nurses, none of this would have been able to happen. And it was them who, when, I don't want to jump too far ahead, but
yes,
when they were approached, when CVU was approached by Hoffman LaRoche to do these trials, the INH had never been tested on human beings before. And so, and I will put it, say it out, this was not a Tuskegee thing. They got consent from every single
yes,
patient. Robichek was not an immoral person that way, which was also pretty incredible, because this was the dawning of drug trials. There were no federal regulations. They were kind of making it up as you went along.
yes,
Anyway, he got consent, and they had no data on how the drug was going to affect humans. That data came from those nurses who stood on the front lines in the wards every day
yes,
and looked at the mental, physical, and emotional state of patients who they knew for many years, because many of the patients at Seaview remained at Seaview. Medical cards tell the story. There were some that were there 1,000 days. So they knew these patients, and they knew the nuance of tuberculosis, like how vicious it could be, how, it ebbed and it flowed. And so they were able to really, when they started giving this drug, they knew what was, quote, normal for the disease and what wasn't.
yes. That's true. I was just curious to know, Maria, at least in your part of the world or what you see around you, do racism and health inequities still plague uh, even countries like the USA and the rest of the world?
Oh, that's an absolute yes. I mean, I'm not a doctor. I'm not in the
Mm,
medical world, but from what I have seen, and
yes,
the last year talking about the book, what I have heard,
yes,
and just experiences that people have told me, absolutely. We have the healthcare system here is a 2-tiered healthcare system that's really based on the haves and have-nots. That's the way it's become. um I can speak for myself.
yes,
You'd be hard pressed in New York City to find right now a gynecologist that will take your insurance, even if you have good insurance, because it takes so long to process. And if, you know, my OBGYN that delivered my daughter retired shortly thereafter she was born, and I asked her why, and she said, because it's taking me 20 to 30 minutes a patient to process healthy people. If a patient needs a service where I have to fight for them to get that, that could take the secretary, the woman who's her assistant, who was processing the insurance and stuff, up to 2-3 hours a day. So it is a very like entangled system now. You know, and across the country, you know, there's people in the class that I'm teaching at Columbia University, a student just wrote, 24 years old, this harrowing story of the sexism that she encountered trying to get this gynecology. She had endometriosis, trying to get it diagnosed for 3 years, and people gaslighting her and telling her there was nothing wrong with her. She was 24 years old. So yeah, it absolutely exists in this country.
Yes, and you can imagine the situations are worse in other countries or just the same. And when it comes to an infectious disease like TB, which is said to be a disease of the poor, these inequalities, they exacerbate still more, because those are the people who are maybe living outside of the normal society or deemed to be not to be existing there at all. And on top of that, if you are a woman, then God perhaps also can't help you, because then it multiplies, the problems multiply. Because I have seen the same disease. They say that the TB bacteria affects everyone the same way. But when you see the social situation, it affects the women in a much worse form, because they are the caregivers, caretakers, patients, everything combined into one. So thank you, Maria, for being here. And I'm sure this must have created a lot of interest for your book amongst our viewers today, to read it and go through all that patient work which you have done. You took such a long time to produce such a gem of a book.
I just want to say, if you're ordering the book from
Yes.
any kind of US website, only order the one from the cover in the back, because there's a blue version, a paperback on the US Amazon site that is not authorized by the United States. However, if you're ordering it from like the UK, that is the authorized cover, but it should not be sold. The paperback version that's being sold on the United States Amazon site is not authorized by the United States. So this cover is the one that you should buy if you get it here, order it from anywhere else in the United States.
Okay, thank you. Thank you, Maria. Thank you very much.
Thank you.
Thank you. And now I welcome Ella Gandhi, a South African peace activist and former politician. She served as a member of parliament in South Africa from 1994 to 2004. She is also the granddaughter of Mahatma Gandhi, who's a very well-known figure from in India, still remembered, and worldwide. Ella Gandhi fought tirelessly to end apartheid and achieve social justice in South Africa. I have had the honor of meeting her in Durban in 2016. Ella ji, welcome, and please share your experiences of fighting for social and health justice during apartheid in South Africa.
Thank you so much. Thank you for inviting me. And I want to recognize the panelists here. I missed part of Ms. Smilios' speech because I had some difficulty connecting. But just to recognize all of you here on the panel. Looking at the historic background of TB, I was shocked to see the manner in which this account of our history is dealt with. Its introductory paragraph states, and I quote, on March 24th, 1882, Dr. Robert Koch announced the discovery of the mycobacterium tuberculosis, the bacteria that causes TB. During this time, TB killed 1 out of every 7 people living in the United States. Living in the United States and Europe. Dr. Koch's discovery was the most important step taken towards the control and elimination of this deadly disease. Now, there was absolutely no mention of the people dying in Asia and Africa. It was just about Europe and USA. And this is the history that's recorded. TB was found to exist, I believe, 3,300 years ago in India. This is the pattern we see all through the ages. Black lives do not matter. And when I say black, it is inclusive of all non-whites. We are still grappling with health equity issues, although perhaps Mother Teresa would be an exception to this notion. In South Africa, I worked with families of TB sufferers. As a child and family welfare society, we worked in the most poverty-stricken neighborhoods. An organization by the name of Friends of the Sick Association was formed in 1941, and it was supported by the International Fellowship of Reconciliation. A piece of land was acquired by this group, and a team of volunteers were recruited and trained. These volunteers were identified from the various neighborhoods in the Durban area. The teams would then visit families in the neighborhood, educating people on TB. The process helped in firstly demystifying the disease and alerting people on what symptoms to look out for, and reassuring families that the person can be cured. But importantly, part of the training was to impress on people that early detection can help in the cure, and secondly, that the disease can rapidly spread unless very stringent hygienic controls were maintained. This education also helped to destigmatize the notion of TB. As we know, it used to be called consumption, many other names, and at that time people would hide. They wouldn't tell anyone that they suffered from this disease. The visits also led to early detection and treatment plan, including the possibility of taking the families to the Fosa settlement, where they would be taken care of with nutritious food and a hygienic place to stay. I agree that this is temporary until the family gets well, but then they go back into the same, possibly living on the streets or living in unhygienic conditions in large settlements. But that is the position that the poor are relegated to. The sufferer would be hospitalized in the same precinct at Fosa and would be treated. In this way, the spread of the disease was controlled, as well as the health care of the entire family. On the home visits, volunteers also took food parcels and possible medication to the homes. But again, as I said, unless you have proper hygienic conditions, people will again and again get ill. So the most important thing is for poor people to be able to acquire good hygienic residential accommodation, and secondly, nutrition. But this system of neighborhood watch was indeed one of the most effective systems that had been put in place in those early days of the work of FOSA. The only problem was that they were not able to extend the services to African people because of the apartheid laws, and because most of the African families were confined to reserves. But there were some African families that were identified in urban areas and taken in unofficially for care. The need for vaccination, which was discovered much later, was also part of the education program. And we encouraged every family to ensure that everyone was vaccinated, assuring them of the important preventive effect of vaccination against this deadly disease. But again, it was quite a task to do this because of the many myths surrounding vaccination and this kind of medication. To this day, however, there is a great need for education, particularly against stigma. In recent times, HIV/AIDS has had an effect of linking with TB as well. And there is still a stigma against HIV and AIDS, and now against TB as well. This causes further possibility of spread of this disease. In recent times, the government has taken over healthcare services of TB patients, and so the FOSA settlement that was established many years ago, unfortunately, has closed down. The attention is now on diabetes, the people who were working for FOSA. While education is still provided through various channels, the neighborhood system has completely dissolved. And I think that that system is one of the best systems in identifying, getting help, and making sure that people don't spread the disease and that they look for proper cures, because TB can be cured. And so going forward, I believe that we need three important interventions. Firstly, a carefully crafted education with neighborhood groups that would impart this kind of education to people. And today, we have a need for education for so many diseases. COVID has shown us that, we are so vulnerable and we are so dependent. Yet, when it comes to the poor, there is hardly any service provided for the poor. The second is that the importance of nutritious diet has to be, imparted to everyone. The need for nutritious diet, because without that, that you can't be cured and you can't prevent as well. The third point is that continuous struggle at international level for equity in healthcare, and also at local level to rid our society of poverty, because poverty is the biggest problem, and we need to look for ways to get rid of poverty. The system of patents and controls by the West of the medicine, and the control of who gets urgent supplies when needed, cannot continue. This was exposed during the COVID pandemic, and we have to do something about it going forward so that it isn't repeated. The lives of people must be paramount in all healthcare matters. So I would say that we need to get, apart from these three things, We need to get rid of poverty. We need to have accessible health care for everyone. And we need to have medication available at rates that people can afford. Thank you so much for giving me this opportunity.
And thank you, Elaji. It was a real pleasure to hear you speak and really speak from the point of view of not just an activist or advocate, but a scientist's point of view. Prevention is always the best medicine. And for prevention, as you said, nutrition, because recently a study was done in India, and even the Lancet recognizes it calls food nutrition to be a vaccine for TB. If you get good nutrition, then you do not get the disease. And all this needs social equity, as you mentioned, equity in healthcare plus removing poverty. And I'm happy you brought up the medicine supply issue also, the highly priced medicines. And recently we have that example of a medicine for HIV, a PrEP medicine, a long injectable, Lenacapavir, which has been developed by Gilead, and it is currently priced at $44,000 for a year's treatment, consisting of 2 injections in USA. They have said that prices will be brought down, but to what extent we do not know. And Africa was a major country which took part. Many countries in Africa took part in the trial for that. So that question of patents and not making medicines available at reasonable prices to people for whom they were actually developed, for those who need them. I think those are very good points, and we need to work on that. And with stalwarts like you there to guide us, I'm sure someday, I hope we will be able to achieve that sort of a world order. Thank you very much, Elaji. Our next speaker is my dear friend Tariro Kodatsa, an HIV/TB advocate based in Zimbabwe. She represents civil society organizations and people infected and affected by HIV and tuberculosis in several national, regional, and global health-related committees. She is also the founder leader of TB People Zimbabwe and has played key leadership roles in Zimbabwe National Network of People Living with HIV, that is ZNNP+, among others. Welcome, Tariro. The floor is yours.
Thank you so much, Shoba, and thank you so much for this opportunity. I'm so delighted to see Virginia in face to face. Though I'm far away, but I'm so delighted. So I stand before you today, proud of Virginia and all the Black Angel nurses who dedicated their lives in caring for patients without prejudice or discrimination 100 years ago. What is most important is they were working in the most contagious sanatoriums, but they didn't tire. These remarkable women exemplify the highest ideal of humanity by providing care to everyone, regardless of race, nationality, or socioeconomic status. TB was so called so many names, a disease for the poor, but they did not tire. They didn't look into that. They treated white patients, Black patients, Latinos, Africans, Asians, rich and poor, alike with compassion and dignity. However, this raises a critical question: where were our counterparts in the noble endeavor? Many other white nurses chose to stay away, but they soldier on. This historical neglect highlights a persistent inequality and injustice that continues to plague the TB response today. If we look even our funding space, our funding landscape, TB is always having the little share of the cake. So it continues from very far away. So what is the global burden of TB? Today, most of the TB burden is concentrated in the low and middle income countries in global south, regions in Africa, Latin America, Asia, the Pacific, Eastern Europe, and Central Asia. Each year, over 10.6 million new TB infections are reported global. Despite being preventable and curable, we witness a staggering 1.3 million deaths from TB annually. And when you talk numbers, it becomes like it's very light. But these numbers are people. 1.3 million deaths from TB annual. This is not just a public health crisis. It is a human rights crisis. The reality is clear. TB anywhere is TB everywhere. The marginalized populations in wealthy nations also face higher risk of TB infection. For instance, in the United States, American Indian, Alaska Native, Asian, Black, Hispanic populations experience significantly higher rates of TB compared to their white counterparts. Yet it is in the global south where most new infections occur and where systematic injustice continue to deny individual access to life-saving care. There's a lot of systematic inequalities in the diagnosis and the treatment of TB. Consider how we diagnose TB. In wealthy nations, advanced WHO recommended molecular tests are used to identify cases promptly and initiate treatment with the latest regimens. In stark contrast, countries in the global south, we still rely on sputum microscopy and an outdated method that misses more than half of TB cases, and we never meet the targets. This is underperformance, leads to unchecked transmission and increased suffering. Recently, a single TB case reported in Long Island prompted a public health emergency declaration, complete with extensive contact tracing. Imagine that a single case triggered immediate action, while millions in the global south live within untreated TB every day without adequate resources or attention. Let's be the Virginias of today. And what should we call as Virginias of today? The call for accountability is on board. We must ask ourselves, when will we hold ourselves accountable for these disparities? It has been 10 to 15 years since these recommended new diagnostic tools were on the market, became available everywhere, but why are they not deployed at the point of the need for those who need them most? We are saying bring diagnostic tools at the doorsteps where there's the need. Yes, science says we miss people, mathematical modeling says we miss people, but we are saying as advocates, we are there in our congregate societies. We are there in our minds. We are there in our farms. We are there in our villages and so forth. Just to bring the diagnostic closer to the people. New treatments like pidaliquine and delamanid have been available for years, yet they are not reaching all high-burden countries. This delay in rolling out essential health technologies perpetuates injustice and suffering among vulnerable populations. Where do we want to go? The Virginias of today. We should have a vision for equitable healthcare. We can end TB. Yes, we can end TB. Now, if we confront inequity head on, we can end TB if we ensure that all individuals have access to the best TB services, in a people-centered and rights-based manner. Number one, deploy advanced diagnostic tools. We must bring WHO recommended new tests directly to communities at risk. Number two, expand treatment access. Ensure that the innovative treatments reach every corner of high-burden countries. Number three, integrate services. Combine TB care with the broad health initiatives to improve overall health outcomes. Number five, ensure accountability, not only to the government, nor to the global organizations. Accountability to everyone, implementers, everyone. We must be held accountable to the commitments to eradicate TB. We were in New York 2018. We set targets, we did not meet them. We were there 2023, we set targets. And when we said 2030, it seems like it's a long, long way. It is not. 2030 is here. There are just a few months around the corner. Are we going to eradicate TB? Why are we not eradicating TB when it is curable and treatable? That is a take-home question. That is a take-home question. And in conclusion, the Lakers Black Angel Nurses serves as a powerful reminder of what it means to save humanity without prejudice. As we confront the ongoing challenges posed by tuberculosis today, let us remember that all lives matter, including those in the global south who continue to bear the brunt of this preventable disease. It is time for action. It is time for equity. Together, we can ensure that no one is left behind in our fight against tuberculosis, a fight that transcends borders, races, and socioeconomic divides. Let us honor the past by committing ourselves to justice in healthcare today. This extended vision should be closer to your desire to maintain that TB will be a disease of the past. I thank you.
Thank you very much, Tariro. And I say amen to what you have said in the last, that let it be a disease of the past. And thank you for your very powerful messages which you have given today.
Shobha, can I just jump in and say one
Yes,
thing in response
please.
to that?
Yes.
The question you had asked about how inequities plague America, I think I want to pick up on both what Ms. Gandhi had said and Tariro said. Part of the inequities is that we don't see people beyond, we don't even see each other in this country as equal. So to look beyond the borders of America and turn our eyes to people who are suffering from a disease that should be eradicated because it's a disease that says cure and leading infectious disease killer in the world in one sentence. And that is like one of those Buddhist koans that hammer on the walls of logic. How do you have cure and #1 infectious disease killer in the same sentence? The reason you have it is because we turn ourselves eyes in the other direction and say, it does not concern us here. And that case of the one tuberculosis case in Long Island is a perfect example. We can control it here in the United States because we have the tools and the medicine, and we don't want another TB epidemic here. But when we look at people who are living out of our boundaries, out of our purview, people don't matter. They don't matter. They are continued to be othered and stigmatized. It's the same old story of the way they perceive the patients who went to Seaview, who were predominantly African-American and immigrants who came over. They were, quote, un-American, uncultured, uncouth, unworthy of care. And we see that today. You know, I studied when I was in graduate school with Elie Wiesel, who survived Auschwitz. And he walked in the first day of class and he rolled up his sleeve and he showed us his number. And he said to us, you know, in this class, you are going to bear witness to a story. And it is on us that every time we see an injustice, it could be a grave injustice as big as the Holocaust, or an injustice of pushing somebody, when they shouldn't be pushed. He said, you cannot turn away. When you see it, when you hear it, when you read it, you have to do something about it. And I think in today's world, we're not thinking about what it means to bear witness. And the world knows what's going on. They're not ignorant. You just turn on social media, and there's like me and 10 other people here trying to fight for equitable and accessible care to get new diagnostic tools to these places. Everybody else scrolls on by. I was writing the book and people said to me, what are you writing about that disease for? It's finished, or it's not so bad. It's like bronchitis. So I just wanted to add that, when we talk about health inequities, I wanted to add that part of that is the health inequities are because we don't look beyond ourselves. And the people here who need them are similar to the people in these countries who are, who have less means. The rich are going to get care all the time. They always have, and they always will. The people who need it most, so anyway, I just wanted to piggyback on that because I think it was an important point to say that health inequities exist because we continue to other people.
Thank you, Maria. Thank you for bringing up a very good point. And it's not just that you are saying that we don't look beyond our borders. In my own city, I live in India. Sometimes people say, does TB still exist? The Indians who are living here, and it is the highest TB burden country in the world. And still they are not aware, or as you say, they don't want to care. They don't want to get out of their bubble. And as it is something, as long as I am safe and happy, doesn't matter what happens to the rest of the world. So
Right.
that is the feeling here also. And like in India, and I think in other, at least Asia Pacific countries, there may be not a divide of race and ethnicity. There is a huge divide of caste, creed, and social status, and which is similar to in different ways of what you have in your country.
Yeah, it's
So
I was just going to say, like, another
Yes.
reason I wrote the book is because when I heard this story, it was one of those things where I was like, you can't turn away from all of these people who had gotten sick and were buried in a potter's field and were considered inhuman because they were the sum of their illness,
Yes.
And that is what's happened now. It's people who are sick become the sum of their illness.
Yes.
So
and since you have brought this up, and Ilaji brought up the gave the example of COVID-19. In COVID-19 also, the inequities came up so clearly, and even to the extent that at least I saw in my country and in my neighborhood, somebody, because everyone and anyone was getting infected with the virus, they said, we got it from someone, from the person who's poorer to us, from our driver, from the household help, as if they were the carriers of the virus and not the people who belong to the upper strata of society. Always the blame was on the others, not on us. Like it could be anybody who could have given you the virus, who could have given you the infection.
Well,
But
in the United States, in the United States, it was first peddled as a, quote, Chinese disease, in the same way AIDS was a gay disease and TB was a disease of the poor.
The poor.
So it was the same stigma that was, tacked onto that. Same thing.
Yes. And thank you for bringing this up so well, Maria.
Thank you.
I now invite Dr. Tara Singh Baum, who has relentlessly called for people-centered health responses and to connect the dots between tuberculosis and other health and development issues. And he is a great crusader for local action, that the actions we take locally, they will have a global impact. Dr. Baum is the board director of Asia Pacific Cities Alliance for Health and Development, which is more commonly known as APCAT, and he serves as Asia Pacific Director for Tobacco Control at Vital Strategies. Welcome, Dr. Baum.
Thank you very much. Can you hear me?
Yes, we can hear you.
I don't know whether you can see my slides.
Yes, we can.
Okay, excellent. So thanks to all the speakers and the distinguished participants here. It is really interesting, the discussion. It's a century, like it's just the title of this, the webinar as well. And we have been working for a long, long time, the generation to generation, but still TV is still there. And still we are struggling with this. So for this, the brief presentation, I'm going to highlight the role of the leaderships at the local level, and also highlighting some key points, more focus on the how can we really integrate the tobacco smoking cessation within the TB control program or TB elimination program, and why. So if we just say, the International Union Against TB and Lung Disease, I'm the member of this organization. I also worked for a long time with this organization. The missions and the vision of this organization is very clear: to eliminate tuberculosis. And also the union believes on three key points, that is early screening, early diagnosis, and early treatments. I think these are the three key variables that we have discussed now, and we have been discussing for a long time. And this is something that needs to be done at the local level, and it is in every country, wherever we live. So just highlighting the global burden of TB and tobacco. As we know, there are 10 million TB people around the world, and also every year over 1.3 million people die due to TB. So for tobacco, the use is over 1 billion, tobacco users globally, and every year more than 8 million people die due to tobacco related diseases. And if we look at the TB and tobacco, about even over 700,000 people are attributable, the TB attributable to tobacco smoking. And of the 8 million people, 16% of death by TB are attributable to tobacco smoking as well. So this is something really a deadly intersection, and it's one of the deadly co-epidemic as well. If you look at some quick highlights here from the high burden countries, high burden of TB and high burden of tobacco. If we look at the risk factors, there are 5 key risk factors for tuberculosis. These risk factors have been identified by the WHO and published almost every year in a WHO annual report. But we don't see much action, toward this the risk factor. So if you look at for example, like we're talking about in India, smoking is almost a third largest risk factor. Of course, the malnutrition is one of the major risk factors, followed by the alcohol use. And then in Indonesia, on the other hand, the smoking is one of the main risk factors in Indonesia. It's more than 30% of TB are attributable to tobacco smoking only in Indonesia. It means, if we translate in numbers, so in Indonesia, over 1 million TB are estimated each year. And of the 1 million, over 300,000 people with TB are attributable to tobacco smoking. So it's a huge, huge burden, and it can be addressed easily through many the policies and programs and the action. So if you look at the number of total TB cases and TB cases, by country, so I don't need to explain to all here. As I mentioned, Indonesia, so more than 30% TBs are attributable to tobacco smoking, while in India it's like 8%. Similarly, you can look at in other countries like in China, 20%, Philippines, 29%, Pakistan, 17%, Bangladesh also is quite high, more than 20%. Myanmar is another country that's, the tobacco, the burden is quite, huge, and both smoking and smokeless, the tobacco is a huge problem in Myanmar. And if you look at translate this into TB burden over almost 30% of the TB attributable to tobacco use in Myanmar. So it's overall, the smoking, as we know, smoking increase the risk of TB, and also the also risk of death. About the 16% of global the TB deaths are attributable to tobacco smoking, and if, in the countries we can see a big variation from 13% to 25%. China is the leading, followed by the Nepal. In Nepal, about 20% of the TB deaths are attributable to tobacco smoking. So just to quickly highlight, tobacco smoking is one of the key risk factors for the whole pathway of the TB, from from infection to the death. So it's a major risk factor that I would like to conclude here like this. So also if you look at it's not only the treatment, but also tobacco smoking really poses significant the barrier for the people to seek help as early as possible. That means it's a significant factor to delay the people to find out the health seeking in any sector, whether it's private sector or public sector. So in Nepal, this is the study that we have done a long time back, but we found that the smoker, they have significant delay in seeking the TB diagnosis and TB treatments. So, and one of the main reasons that we asked to the people why do they come, they very late in a health facility to seek help, and the answer was very clear, because their cough, whatever they have, the cough is because of the tobacco smoking. That's they perceive like that. So it's not something wrong with their health, but they perceive it's, oh, I'm a smoker, so my cough is because of smoking. That's why that's the reasons to delay in health seeking. So that's the issue of the tobacco smoking and TB at the global level. So how can we address this problem? We can do the TB control program and tobacco control program can work together to really ensure the action on the ground. So one of the key factors, like the Soba also mentioned, the APICAT, Asia Pacific Cities Alliance for Health and Developments, is a mayor alliance in Asia Pacific countries, and that the mayors are more responsible for their people in their locality, in the city, and in their jurisdiction. This is one of the example here. You can see, the mayors. The photo, the picture in the left side is the mayor of the Bogor city in Indonesia, and the picture in the right side, that is the mayors from Bangladesh. They all are working together to really identify the local solution to address the problem of tobacco smoking through development of the local legislation, the policies, and putting all the efforts for implementation and enforcement. Same thing they are trying to do for TB, the elimination programs by generating the awareness campaign, and also facilitating for early diagnosis and early detections, and also support the treatments, as well as the leaders at the local level. They have a great responsibility, I would say, to really engage all the people together and reduce the stigma related to TB and other any diseases. So we can see a greater role of the local leaders to ensure all the services are provided at the local level and near to the people's the home, and also the very much the center. They can put all the resources together to center the TB patient as well. So what action that this is just one of the interventions that was implemented in some of the countries. Just one action through the local leadership is the advice for smoking cessation within the TB control program. So that we call ABC, and this intervention has been done in many countries, in many high-burden countries. For example, in China, Indonesia, Bangladesh, India, and some other countries as well. So if you look at the integration of brief advice of smoking cessation in TB control program, the results are really encouraging. So what the local, the authorities, the local health office, the health centers, what they have done, they just ask the people who receive the TB treatments, whether they use tobacco or they smoke tobacco or any other tobacco products. So it's a very easy, just they ask the one question, do you smoke? So if you throw this one question, if you look at the prevalence of smoking among the TB patient in many countries, especially among the male, almost 90% in India, and Indonesia, almost all, over 96% of the TB people, they are TB male patients, they used to smoke. In South Africa, it's about 43%. In Nepal, it's about 77%. So it's a really high among the male TB patients compared to the females, but it's still quite high compared to the general population. That means in the developing countries, especially in Asia, many the people they smoke, especially male, and we observe the very high prevalence of tobacco smoking among TB people. So through this intervention, the ABC acts, brief advice, and provide the cessation support through the regular TB services. What we have achieved, we achieved in Bangladesh over 82% the smoking cessation rates among the TB patients in 6 months. That's very remarkable. It doesn't require any additional money. What it requires the local governments, the leadership, and local governments' accountability, and engage the many other stakeholders at the community levels. That is needed. So in India, also even it's a high burden settings. The quit rates was quite significant, over 67%. Similar in Indonesia and China. So that we observe in many high burden countries. So in Brazil, so it was only it's a one time. That means in the first month, only the TB patient they used to receive the smoking cessation, but the rest of the month they didn't receive. So, but again, we can see the one session of smoking cessation also produced good results. Like for example, 15% quit rates in Brazil through the primary healthcare settings. So that I would like to skip this about that. When we look at the impact, the benefit of the smoking cessation in TB treatment outcome, if you look at here the results from the Bangladesh and Pakistan, the treatment success rate was quite high, like significantly high among the quitters compared to the non-quitters. Even if you look at the TB relapse, the TB, the relapse is quite high, almost double among the non-quitters compared to the quitters. So there are lots of benefits of integrating the smoking cessation within the TB control program. It's not only the health benefit, but also the economic benefit as well. The people, the TB, the people with the TB, they can save money and they can save their health from the risk of other diseases as well. So therefore, we can conclude that smoking cessation has multiple benefits with a very minimum resources, so that can be spent and also it can be integrated within the regular TB services as well. As I mentioned, there are only benefits, and also it can really help to early diagnosis, early treatments, and also the prevention of the TB disease among the communities. So what I would like to say something here is, now many countries in our region, I think it's similar in other the continent as well, still we talk about the elimination, but we do the activities on the ground only to control the TB. We are not focusing the problem. Actually, the problem at large but we are trying to solve the some issue as an ad hoc basis. I think that is something we need to change the scenario. Therefore, we need to have a TB legislation in each and every country. I think global community has to come up for a stronger TB law. So TB treatments, TB diagnosis, TB services should be mandatory. And it should cover all aspects of the TB services, including the justice, including the rights, including the patient-centered approach. All the things needs to be included in the TB law, and it should be mandatory. Then only we can go for the elimination. Therefore, now the focus currently only for the TB, people with the TB, I would say. But we are not talking about the people without TB. So the people without TB, they have also right to to not to get the TB disease. So we need to also empower them. We need to build such a the strong mass media campaign, strong public education to really protect their health as well. So everything should be included within the TB law. So therefore, I think in some countries there are some sort of the regulation, but those needs to be relook, and also we all need to strongly advocate for the national legislation on TB. So the other thing is we always talk about the resource constraint. I think that there are multiple sources that can be identified and also put the higher tax on those products, for example, tobacco, alcohol, sugary, and sweetened beverage. So the governments and these all the products are harmful to our health. So we know that. So we can make a strong regulation. We can government can make a strong regulation on this and put a higher tobacco taxation on all these harmful products as well. So that some portion of that the money from those the taxes can be used for the tobacco control program, for TB elimination programs, or any other public health program, including the universal health care. So therefore, I think we need to find everyone needs to be screened, especially in our setting, in a developing setting, and also everyone needs to be treated with dignity, with justice. So I think that is the key thing that we need to do. Otherwise, we'll repeat the slides over and over in coming years, and there must be something different in the different methodology and different strategy. We need to think out of box. I think I stop here. Over to you, Shobha.
Thank you very much, Dr. Baum, and thank you for bringing out the point that we have to focus on people who do not have TB also, to ensure that they do not get the disease in future. And also talking about the TB law and how tobacco is affecting tuberculosis, the treatment of tuberculosis and the cure for it. And in fact, there is a comment from Loyola that the tobacco industry protects its markets and interferes in health policy despite global tobacco treaty. So we need stronger action to hold industry to account. And would you like to comment on that, Dr. Baum, before we move on to the next speaker?
Oh, sorry, would you mind to repeat?
Yes, Loyola says that, but the tobacco industry protects its markets and interferes in health policy of governments despite global tobacco treaty. So we need stronger action to hold industry to account.
Exactly, we need to. I think this is all about I would like to put on a different way, very straightforward. So many governments, people, they are corrupted. So why tobacco industry easy access to them? Because there is a corruption. So the global community now needs to be united and to ensure that to hold the governments that they follow the WHO framework convention on tobacco control, the Article 5.3. That needs to be implemented. and respected by all the governments. So all the civil societies, actually the media, and we all can really hold the governments and make them more accountable, not to have any interference with or any love or engagement with the tobacco industry. And similar like with the other industry as well, alcohol and others.
Yes,
Sugar.
yes, thank you. We will now hear from Sumit Mitra, a force to reckon with on shining a spotlight on a less talked about, but the deadly divide between the global south and the global north. He serves as president of Molbio Diagnostics, and here is his video message.
Thank you, Bobby, for again giving me this opportunity to share my views. And what you just narrated on this living legend is so inspiring. And just as the topic of discussion for engaging today is the two I's, injustice and inequity. Today, I will take a slightly different approach by kind of giving a theme to my narrative as being the two I versus the three I's of Molbio. So I'll give you the three I's, the two I's from what you've said as part of the discussion. The global discussion is all about injustices and inequity in the TB diagnostic landscape that has been there from times immemorial. You've only said over the last century, but I would assume that it has been there all along and it still exists today. And you say so very consciously that it is no longer acceptable. So what as a TB community have we done? And I will just give you today, for today's engagement, the three I's from Molbio's perspective. As a company which is into molecular diagnostics and TB being one of our very, very high priority and high focused areas, the three I's that I spoke about is innovate, impact, and inspire. So just as this lady's story, Virginia's story, inspires all of us, and at this age, I think she is nearing a century, right? And she's still working. She does her own chores, etc. We get inspired by people who have been through all of it, seen through all of it, seen through the inequities, seen through the injustices, and we say, hey, we've come a long way. How far are we going to stick with all of these rubbish? So the three I's of Molbio versus the two I's of this program stands out in very stark contrast. And I can say that at the end of it, not only numerically, because 3 is always going to be stronger than 2 mathematically, but when we put a plan in action and when we say that we are going to innovate the way the world needs it, Molbio is going to keep innovating the way the world needs it, making it simple, simpler, and simplest so that we know where the last mile gaps are. We know where the last mile disconnects are. We know where the last mile needs are, so that through our innovation, we provide access and therefore take the inequity out of the whole equation. So one is, injustices can always be taken care by proactive people, proactive communities, proactive organizations, and I believe ours to be one such organization. And inequities can always be taken care once you identify the gaps, which we believe to a certain extent that we have. I'm not saying that we have identified all the gaps. Therefore, the 2I of injustice and inequities versus our own 3Is of innovation, impact, and inspire, while being entirely contra to each other, is also complementary, because you're all actually helping to erase the inequities that existed, to erase the injustices that existed and still exists. How do we do that? So for the last 2-3 years, and for the last 1 year being more specific, we've always been talking of taking services to the people. And we know we've done programs on this, people have spoken on this. So Literally, when you take services to the people, you are actually empowering them. And we talk about empowering our communities. We are talking about making our communities demand rather than beg and make a meek request. We are telling our communities, look, this is your body. This is your body, and therefore you are at full liberty to ask for remedial measures should your body be affected by TB or, for that matter, any other pathogen. So when you are playing the role of an enabler by bringing technology closer to them, you're actually empowering them, you're making them feel much better. You make early diagnosis possible and correct diagnosis possible, so that the stories that we hear at the various TB forums of the TB survivors, and one thing common in all the stories were, what if I were to be diagnosed as early as it is possible today? All that has become of me, and I'm talking of those survivors, and these are so heartbreaking stories. All that has become of me today is because I just did not get diagnosed correctly and early enough. So when you hear these kind of stories and you hear of the inequities and the injustices over decades and centuries, and as you rightly said, no more, enough is enough. But on the other hand, folks like us, folks in the industry, folks in the scientific community, folks within the universities have to develop technologies, have to bring out tools that erase those such hard to take words like inequities and injustices. So the Molbio 3 I's of innovation, and as you are aware, the TB world is today experiencing the impact of the Molbio innovation, not only allows for early detection and therefore creating a very, very significant difference in the lifestyle or in the overall life progression of a TB patient who has been infected, but also by ensuring that these tools are being made accessible to the very last mile, where there is absolutely or was absolutely no access because of whatever. And today you have access. So I think the combination of our tool, our intent, our innovation, our ideas, and then all culminating in the form of a product that is easy to use, no compromise on the science per se, and readily deployable in the farthest corners of the country, will go a long way to alleviate the pains that we feel from the inequities and the injustices that have occurred over decades and centuries, as we say, in this landscape of TB. Of course, our narrative is today on TB, but the same thing can happen with any other disease, right? We've just been through one pandemic. The words that are around the scientific community is that over the next couple of decades, there will be many more pandemics. And the worrisome scenario is that the frequency of these pandemics will become much more frequent, much more shorter. The frequencies will become much more shorter. So when you have invested in this type of innovation or other innovations that are coming into the market, you're providing proactively a diagnostic infra for any country, whether it's in the high impact country or countries in the the emerging countries, as they say, of which India is also one. You're making them proactively ready. The pandemic also taught us that when a pandemic happens, whether in a low-income country or a high-income country, the barriers of injustices and the inequities vanish. The pathogens do not discriminate between whether you are from the global north or the global south, rich or the not so rich, in the developed countries or in the emerging countries. So you could be hit equally bad. So there is a lot of learning from all this that we've gone through over the years, especially the recent pandemic that we had, that enough is enough. Let us say that this kind of inequities must be dealt with, must be taken out of the equation, and this type of injustices must be taken out of the equation as well. And I'm happy to tell you, Bobby, especially in the, I will not name TB per se, but in the infectious disease world of which we are a part, our bread and butter is infectious disease diagnostics. There is today an awakening, there is today a realization in the global audience that, we need alternatives. We need credible alternatives to even the WHO. Believe me, people are saying, you know what? Evaluations, stuff get, stuck because of the rigors of the processes that the WHO or the evaluation bodies they follow. And therefore, we would like to have something simpler, something that we can do in our own countries, and based on a successful outcome, we can ask our government in terms of a policy decision that go ahead, we have done it on our own, it is good enough. And I don't look at these kind of alternative mechanisms as being in competition to each other. I don't see this as in being competition to the WHO or, world organizations that have been with us for so many years, decades, centuries. I actually see even this occurring, this newfound, enlightening areas of work as being collaborative. Now, I was in a recent discussion with one such alternative body, and I said, you know what? You could actually do this, whatever you're saying that you want to do, and provide data to WHO that helps WHO kind of fast track on decisions that would otherwise take WHO a lot of time. So the idea is that we seek ways, collaborative ways, good collaborations, meaningful collaborations, and not just scratching the surface. That will not work. It has to come from deep within your heart. So good collaborations, heartfelt collaborations, to kind of help each other out, all with the purpose that our communities cannot suffer any longer. Our communities, the TB community specifically for this engagement, cannot and should not and will not wait for a correct diagnostic test to be done at the first point of contact for the patient, which is the community health center, because there are tools available today that allows you to do that. So all in all, for this time, for sure, and as I am learning through all my experiences across the globe, I think the one word that I wish to add is collaboration. And if we collaborate well with like-minded individuals, I see no reason why the injustices or all the inequities that we had can slowly but surely be eliminated, and the world will be a much healthier place. And we all know that a healthy body, a healthy mind, and a healthier world is a happy world.
Thank you very much. And last but not the least, I invite our friend Gabriella Leone, who is the co-curator of the exhibition titled Taking Care, the Black Angels of Seaview Hospital. And this is ongoing at the Staten Island Museum. Thanks a lot, Gaby, for showing us around. When I was there in September, you took such pains to show us around the exhibition in such a powerful and unforgettable manner. Now over to you, Gabriella.
My goodness. Thank you so much, Shobha. And Bobby, I think he's probably on in the background for inviting me. I am honored and humbled to share space with this esteemed panel, and I won't take very long. But just to say that, we opened Taking Care of the Black Angels of Seaview Hospital in January in our museum, which is located on Staten Island, one of the 5 boroughs of New York City. And many of our visitors, we touch a little bit on the ongoing global health crisis. We include the statistic that 3 people die every minute of tuberculosis globally. And many of our visitors are unfortunately unaware of that ongoing crisis. So we're glad to be amplifying this problem and raising awareness about it in the small way that we can. The exhibition is about a courageous group of healthcare workers who answered the call to step in before there was a cure for tuberculosis, who helped bring that cure about. We've been so lucky to work with Maria Smilios and Miss Virginia Allen and have their input on the exhibition. We have heirlooms and objects that belonged to the nurses on display in the gallery. And I think, you know, the quote from Margaret Mead comes to mind, that never doubt the ability of a small group of committed citizens to change the world because nothing else ever has. So I'm really moved this morning by this group of committed citizens and healthcare workers. I'm daunted by the task, the things that I've been learning this morning, but I'm just linking the exhibition in the chat here. And there are resources. There's an oral history with Virginia Allen linked there, as well as another with Carleen Jennings Bennett, who's a nurse who still lives on Staten Island. She worked at CV Hospital. And if that can bring any inspiration to you or help raise awareness to this cause, then I'm really honored to be able to contribute it. Thank you so much.
Thank you, Gabriella. And it does inspire us to do something, but of course, we can never equal the work done by the Black nurses, but in our own small ways, I think we can make some contribution to end this dreaded disease as soon as possible. Thank you very much for being with us today. There is a question. If there are questions, then participants, you please type them in the Q&A box. We have in fact, we have exceeded the time limit which we had set for this session today, but it has been a very inspiring and energizing session and a very, very informative one also, focusing on very important issues. We have a question from George from Zambia for Virginia. And George wants to know that, Virginia, did you also mobilize resources to save lives? How do you support NGOs now across the globe to support the cause of TB-related programs and health in general? Virginia, would you like to respond? If Virginia is still there, she had a very early morning wake up today. Virginia, are you there? Or maybe. Okay. There is another question from Ashok Ramsarup, who's a former senior producer of South Africa Broadcasting Corporation, a very senior journalist. Perhaps the question is directed to Ila Gandhi, but any of the panelists can answer. He wants to know, how did colonialism and imperialism impact TB diagnosis, treatment, and prevention in low-income countries? And his other question is, what role did socioeconomic factors such as poverty and malnutrition play in TB disparities historically? Ilaji, if you want to answer, yes.
Thank you.
Yeah.
Thank you for that question. And sure, Ashok Bhai has a lot of experience in this particular field as one of our journalists from the time of apartheid. I think, I have spoken already in my speech that one of the biggest factors is poverty in perpetuating TB. We saw it with COVID, we saw it with all the pandemics, simply because unless you have proper shelter, unless you have nutrition, and you are able to take care of the person, isolate the person, take care of them, have hygienic conditions, this disease is going to spread. These are all viruses that spread in whatever way they do, but they do spread to other people. And unless we can control that spreading of this virus, it will continue. So poverty, when you are homeless, living on the street, you don't have a proper place, you don't have a bathroom, toilet facilities, then you use the open spaces. And that's how the virus, goes out. We saw similar things with typhoid and malaria as well, where people, because of the poverty, it spreads in those areas where the poor people live. These viruses also affect everyone. You don't have to be poor to get the virus, but you have to have some resources to be cured of the virus, to be cured of TB. So that's where the poverty issue comes in. And, the inequality, the rising inequality between the rich and the poor has to be curbed. We need to look at ways so that you don't have the ultra wealthy on the one side and you have the absolutely deprived people on the other side. And COVID virus has shown us that all those people who were in jobs, for instance, like street cleaning your streets, doing things like that, in their absence, what happened to the people? Yes. So you needed those people. And so my point is that we have to have social justice in terms of economic justice. You need to have access to basic necessities of life. And, that is the only way in which we will be able to deal with these viruses going forward. Thank you.
Thank you very much, Ilaji. And that actually brings to my mind that what we need is a feminist world order, which is based on caring and solidarity. And that is what we need to aim for, where there is justice for all. Would any of the other speakers like to say something or to add some remarks which come to their mind before we come to the close of this session? And I welcome any remarks from others if there are. But we have had a very enriching session today, and just reiterating that while many scientific advances have been made since the times of the Black Angels for prevention, diagnosis, treatment, and care of people living with tuberculosis, they are still not available to an estimated 1.3 million people today who died from tuberculosis in 2022 and 10.6 million people who fell ill with the disease in 2023. So things have changed, but a lot more change is needed. And this when TB is curable and preventable. But as has been pointed out by our panelists, unless we end inequity, injustice, and the deadly divide between rich and the poor, and other forms of discriminations due to color, race, religion, caste, creed, and gender, we will never be able to end TB. Tools to find all TB, treat all TB, and prevent all TB are there. That is why TB rates are at elimination levels in some rich parts of the world. They have been there since decades. We can do better. No one needs to suffer from TB or die from TB globally, or for that matter, from any other curable and preventable disease. Because as has been said, all lives matter. So let us wrap up today's session with the hope that TB response will be equitable and socially just, especially in high TB burden settings. The way Virginia served her call to duty without any prejudice and discrimination, we all need to do so in our own lives and demand and work towards a fair and just world order from our governments. Thank you very much for being with us today. Thank you.
Thank you very much.
Thank you, Bobby.
Oh, Virginia, there was a question for you. Can I ask you again? So since you are here now, George from Zambia wants to know that did you also mobilize resources to save lives? And how do you support NGOs from across the globe to support the cause of TB related programs and health in general?
Well, I did not have the resources to do all of those things that you mentioned, but I think education and availability of the medication, and of course, the outreach to the communities that need the resources and the medication is very important.
Yes.
But I had nothing to do with the policies and procedures. And thank you for inviting me today. It's
Okay,
been quite.
thank you. Before we leave, before we close, can we have a message, a short message from each of our panelists, beginning with Virginia, since you are there on the screen? A short message for our viewers, audience, and for the world at large.
I would say education is a way to reach the masses of people. And we have to be very diligent and not give up and make sure that everyone is given the same opportunity for healthcare.
Thank you. Thank you very much. Maria?
I just want to return to the message that I said, that, you know,
Yes.
we all see each other. We bear witness to each other's suffering, and it's evident what's going on. It's no secret what tuberculosis is. It's, you know, and I think that we need to strive for a more humane world, one where we turn towards each other and look at each other and understand that the suffering that happens 5,000-6,000 miles away is also our suffering, and take it upon ourselves to make sure that, you know, the way the women in this book, if there's one thing that, you know, people can take away from this story, is what these women achieved. And I always say it's an appalling story in many ways, but it is a triumphant story. It tells us there are people who are willing to rise to occasions like we saw in COVID and take care of us when nobody else will. And I think we need to take that to heart and really understand it, and not put it only on the shoulders of those who are on the front lines. You know, as citizens of a world that is very global right now, we need to take a page from them. And as one reviewer said, they teach us to be better people now and in the future. So that can, you know, I hope people who read the book or who don't think about that. Thank you. Thank you for having me.
Thank you. Thank you for being there, Maria. Ilaji, one last message to wind up.
I think from our experience, you know, there are lots of people who are caring, compassionate, want to do something, but don't know how they should be involved. So I think collaboration, getting people, recruiting people, educating them, skilling them, and asking them to, you know, go out and do some things in their neighborhood is of paramount importance, because that's how we build solidarity.
Yes, thank you. Dr. Baum?
Yeah, thanks. I think everyone should be protected, you know, from TB by law. So it's the national legislation, the local legislation needs to be endorsed, and everybody's rights needs to be protected.
Thank you. Gabriella?
I think first, thank you for having me, and thank you. My big message is thank you to everyone who's working so hard to end TB globally. I think my message is simply that you can find something, whether it's sharing a resource or telling your community what's going on, what you know, what you've learned, learn things and pass the things you've learned on. And maybe that you can contribute just a little bit to this major crisis.
Thanks once again to all our speakers and to our... Oh, sorry, Tariro is there. Sorry, I've missed Tariro. Tariro.
Okay.
Yes. Sorry, Tariro.
My last word is yes, we can and we will end TB. Only if we will reach out our communities with information. Thank you for the opportunity.
Thank you. And thank you to all the speakers and to our wonderful audience for their time and for their interaction and for being there with us. Thank you very much. Hoping that we will end the disease soon. And again, as I said, let us hope for a feminist world order where nobody is truly and literally left behind. Thank you very much.